Well, thanks for having me. It's an honor to be here and on a beautiful day in Vienna. Natalie and Daniel, thank you very much for the invitation to be here. And as was mentioned, I'm going to talk a little bit about the use of pharmacotherapy for the treatment of pediatric obesity. And just in the way of disclosures, I do some free consulting. I offer my services but don't accept any professional or personal income for that. And also receive some drug and placebo from AstraZeneca for an NIH-funded trial. And I'm definitely going to talk off-label in this presentation. So just in a way of a quick overview, I want to briefly touch on the biology of obesity. So what are some explanations for why the outcomes are so poor or less than desirable, I should say, when we just use lifestyle modification or behavioral therapy? Touch on some of the obesity medications that have been studied in controlled trials, highlight the variability, the heterogeneity in response that's been mentioned briefly this morning, and then talk about what does the pediatric pipeline look like? What are some of the adult obesity medications that have been approved, and what's the timeline, and what does the future look like for those being implemented in the pediatric setting? And then where I see the role of pharmacotherapy in the treatment of obesity and the future of the field of pediatric obesity medicine. So first of all, in talking about the biology of obesity, it really should not come as much of a surprise to us that when we just utilize behavioral modification, the outcomes are less than desirable. That is because all of our bodies are hardwired at a fundamental level to store as much body fat as we possibly can and hold on to that very tightly. An example is that, mostly from the adult literature, is that even modest amounts of weight loss lead to fundamental counter-regulatory changes in our body that are trying to defend that body weight and hold on to that body fat. Examples include even modest weight loss leading to enhanced palatability of food. So that slice of pizza, that cheeseburger that looked pretty good before you lost some weight, all of a sudden looks really good after you lose 5, 10, 15 pounds. There's real data from brain imaging that shows that that's biologically driven. Our satiety signals go down. There are a lot of changes in our gut physiology and hormones that signal to our brain that we are not as full as we should be. And then discouragingly, for many individuals, even children who lose weight, there's often a downregulation in total energy expenditure and resting metabolic rates, such that if someone loses a modest amount of weight, they have to eat many fewer calories to maintain that weight loss than they would have had to at baseline. Here's a real-life example. So this is a young lady from one young lady from our weight management clinic at the University of Minnesota who had a BMI at baseline coming into the clinic near 40. So this easily puts her into the category of severe obesity. She was initially counseled to eliminate liquid calories and add more fruits and vegetables into her diet, and then later her treatment was intensified. She was put on a meal replacement program, so calorically set meals at a level of 1,400 calories a day. The reason for that is her calculated resting metabolic rate was about 1,900 calories, so this would put her in a 500 calorie per day deficit, which should lead to weight loss. So this patient came back swearing that she had worked really hard and adhered perfectly to this caloric regimen that she had been put on, yet she was weight cycling and hadn't lost weight. So the first thing that comes into your mind for all of us, and I'm sure my colleague who's the provider in this situation, was, I don't think you're telling me the truth, because if you were adhering to this diet, you have to be losing weight. Well, it turns out that my colleague, Dr. Fox, decided to actually measure resting metabolic rate with a metabolic cart, and instead of the calculated RMR of 1,900, it was closer to 1,100 kcals per day. So it was her body, probably due to the weight cycling, that was down-regulating and making her metabolic rate more efficient. So what does this mean, though? If we then counsel her to get her into that same 500 kcal per day deficit, what does that mean she can eat per day? It means she can eat either one bagel with cream cheese all day long or a 6-inch sandwich all day long. Now, I'll speak for myself. I could probably adhere to this diet for a day or two, but after that, I wouldn't be able to do it. And if I took I won't ask you to raise your hands, but if I did, and I think if we were being honest, almost every hand would go up and saying we would not be able to adhere to that. So if we want patients to be successful in losing weight, which this young lady clearly needs to do, we probably need to do something to change the underlying physiology, the dysregulated physiology, to give her a fighting chance to adhere to a diet like this and actually experience some success. So that leads me into the transition of what role then could pharmacotherapy play? Well, we're very early on in this field. We have a lot of work to do. We have a lack of evidence base right now, but I wanted to briefly highlight 3 medications that there's a fair amount of data in the literature on, at least for the first 2, and draw your attention to 2 papers. The first review paper is one of my colleagues at the NIDDK in Washington, D.C., Jack Yanofsky. His group published what I consider to be one of the best papers, recent reviews on pediatric obesity pharmacotherapy. And then Justin and I, my group, published this paper a few years later, an update to that review that talks actually more about the future of the field of pediatric obesity medicine and how we could potentially design robust studies to enhance the evidence base. So just briefly, I'm not going to go into detail on all these medications, but orlistat has been relatively well studied, even in the pediatric literature. Now, this medication is approved in the US and in Europe for adult obesity, only approved, to my knowledge, in the US for adolescents, but not in Europe. This is an oral medication. Its mechanism of action is that it inhibits fat absorption, about 30% of the fat that you consume in your diet. The BMI reductions are relatively modest. So I'm going to talk in terms of BMI percent reduction instead of Z-score. Justin alluded to the fact that really in the US we should not be using Z-score when we are looking at the CDC data. In fact, it can be completely wrong sometimes. So I'm going to talk about percent reduction. Very modest, about 2.5% reduction, placebo subtracted with orlistat. And some of the side effects with this medication sort of make you uncomfortable just reading, right? And you can imagine that in adolescent population, these would be intolerable side effects. So we don't have data on it, to my knowledge, but we think that anecdotally, this medication is not often prescribed in the US in adolescents with obesity. The next medication is metformin. This is one that most of us are familiar with. It is approved in Europe and the US for the treatment of type 2 diabetes. It does lead to weight loss. We don't understand how it does that, the mechanism of action, and it's not approved for the treatment of obesity. In the pediatric trials, there's been a number of them, some small, some medium-sized. They show an average reduction of about 3% placebo-subtracted BMI reduction at 1 year. Again, relatively modest, but there have been improvements in some cardiometabolic risk factors. The last one, there's not as much evidence around. My group has been very involved in looking at GLP-1 receptor agonists for the treatment of obesity. This drug class is approved in Europe and the US for the treatment of type 2 diabetes in adults. It's administered by subcutaneous injection, so the first thing you think of is, well, heck, the adolescents, are they even willing to undergo injections? We found that answer strikingly to be yes, and that compliance tends to be relatively high. The mechanisms of action are laid out here, at least what are thought to be. We, in our small trials, have shown about 3 to 4% placebo-subtracted BMI reduction. Again, pretty modest, but we're, it's getting closer to what we'd consider to be clinically significant. And then you can see the side effects are mainly GI-related. I want to touch just briefly on heterogeneity. So all of us who do research in this area, those who are in the clinic, know that there's a high degree of heterogeneity in outcomes. We are working on a paper right now with some colleagues in the US, and this histogram, these are unpublished data, but you can see in this histogram the percent change in BMI in adolescents with different types of interventions. Lifestyle modification therapy alone in red, pharmacotherapy in gray, and then bariatric surgery in blue. One thing that you note right away is that surgery, bariatric surgery, is far and away the most effective treatment for adolescent severe obesity. I don't know that we would really debate that. But interestingly, look at this individual, this red bar right here. This is a person who was only engaging in lifestyle modification, and they did better than many of those who got bariatric surgery. How did that happen? Well, we don't know. And then you can see all the different outcomes here with both lifestyle and surgery. So the point is that there's a high degree of variability, and we need to try to understand what is the source of that heterogeneity. Here's just another example of a study that we recently published about the use of topiramate to treat adolescent obesity. These are the individual trajectories that I think you can see here on the screen. They're all over the place. It's like a plate of spaghetti. Why is it that this individual here in red, who was on placebo, did as well as this individual here that was on medication? Why did we have some on medication that gained weight? We have no idea, but we need to do a better job of trying to understand that. So what are potential sources of heterogeneity? How do we synthesize this and wrap our heads around this? Well, they are probably come from many different domains: genetic, physiological, behavioral, psychosocial, environmental, and I could probably go on and on and on. But we need to sort of conceptualize this so that we can be aware of it in how we design our studies so we can move the field forward. We started to scratch the surface barely in some of our work. I mentioned that we had done some work with Regulatide. We pooled the data from 2 of our pilot studies to try to understand were there baseline factors or early changes that predicted who did better, who had better BMI outcomes on Regulatide. The 2 things that surfaced were female gender. You can see that girls, adolescent girls, tended to do much better in terms of BMI reduction than boys. I just saw a poster here at this meeting that suggested that potentially taste alterations might be more prominent in girls and women versus boys and men, and so that could be one explanation for that. Another was self-reported appetite at baseline. So physiologic hunger, if you use standardized questionnaires, you can get at some of these eating behavior phenotypes of adolescents and understand what is driving their eating behavior and potentially tailor medications accordingly. In this case, GLP-1s may be a good choice of a pharmacotherapy for someone who endorses high levels of physiologic hunger. So this is the field of obesity precision medicine, an area that I think we really need to start thinking long and hard about. It's basically the identification and characterization of the sources of heterogeneity that I discussed earlier. And then here's the key and the challenging part, synthesizing and applying that knowledge and information to select appropriate treatments with the goal of maximizing benefit while minimizing risk. So in other words, to simplify it, this is getting the right treatment to the right patient at the right time. So what about the pediatric pipeline? What does the future hold? Well, this medication here, Lorcaserin, is not approved even for adults in the EU, but is approved in the US for the treatment of adult obesity. It's a serotonin, it acts on the serotonin pathway. Fairly modest weight loss, about 3 to 4% placebo-subtracted weight reduction. Here's the list of side effects. Next medication, the combination of phentermine and topiramate. This apparently did not receive approval in Europe, but is approved for the treatment of adult obesity in the US. It doesn't have the indication for pediatrics, at least yet. This is the combination of phentermine, which is an appetite suppressant by working on the norepinephrine pathway, and then topiramate, which really we don't understand the mechanisms of action in terms of weight loss. But based on the dose, mid versus high, you can get about 7 to 9% placebo-subtracted weight reduction, which I think most would consider to be clinically relevant. Next, the combination of naltrexone and bupropion. This is approved in the EU and in the US. It's administered twice a day. The mechanisms of action you can see here. The weight loss, again, pretty modest, about 3 to 4% among adults, and then the list of side effects associated with that. And then finally, another GLP-1 receptor agonist, the Regulatide, and this one, again, subcutaneous injection, similar to Regulatide. The mechanisms of action are thought to work on appetite and satiety enhancement, appetite suppression and satiety enhancement, I should be clear, and that the efficacy is about 5 to 6% placebo-subtracted weight loss. So what are some medications that are earlier in development? This is semaglutide is one medication that's been presented on here at the ECO meeting. It's also a GLP-1 analog. It's being developed as a once-weekly injection at a relatively high dose. And data presented here and then recently in the US show that in the phase 2 trials, the placebo-subtracted weight loss in adults is about 10%. So now we're getting somewhere. Setmelanotide, I'll just briefly say, is another medication that's being developed by a drug company in Boston in the US. It's an MC4R agonist, and this company is developing it for monogenic causes of obesity. So probably not going to be so relevant for general obesity that most of us deal with, but could potentially be effective for those affected with these single source obesity causes. So as I wrap up, I just wanted to make a point here about the uptake of obesity pharmacotherapy. These are data recently published from the US, and I want to draw your attention first to the right-hand side here. Another chronic disease, type 2 diabetes. I very strongly feel and agree with Jens Christian about the fact that obesity, even in childhood, is a disease. It's dysregulated physiology. It's driven primarily by biology. Anyway, type 2 diabetes, another chronic disease that requires pharmacotherapy. You can see in the US that a little over 5% are medically eligible for medical treatment of diabetes, and the lion's share, the majority of those individuals are receiving medical management for their diabetes. If you look at those, the percentage in the US that are medically eligible for obesity pharmacotherapy, about 45%, only a tiny fraction are actually receiving medical treatment for their disease. Now, we could probably spend an hour debating about what are the reasons for that. I won't go into it, but the fact of the matter is we're not doing a good enough job in taking this disease seriously enough. And if we had data in children, I'm sure the sliver would be about this small. Now, part of that is due to the fact that we don't have a lot of evidence. We need to generate that evidence. But the fact of the matter is when that evidence base does become available, we do need to be aware of this kind of information and make sure that we're treating the patients that need it. So where does pharmacotherapy fit into the treatment spectrum? I would say nowhere yet in pediatrics because we don't have the evidence base. In the future, though, I really believe that it will be, at least in adolescents with severe obesity, first-line treatment along with lifestyle modification therapy. It needs to be both. Medications, surgery, devices will not work well unless it's paired with lifestyle modification counseling. For younger children, youth with moderate obesity, that will probably be further down the road. I mean, you could make an argument that if we have effective and safe medications, perhaps we ought to be utilizing them earlier on in life before obesity becomes entrenched and before too much weight is gained. So what's on the to-do list? Evaluate new agents and rigorously design trials. We need to convince pediatricians, primary care providers, and others that obesity is a refractory, chronic disease requiring aggressive and lifelong treatment. We need to treat this lifelong. So if we think that we can use a medication short term and then take it away and their obesity will stay at bay, we're probably kidding ourselves. The other analogy I would use would be if you treat hypertension, you wouldn't use an ACE inhibitor for 3 months and then cure hypertension and have them come off it. No, if you did that, the patient's blood pressure would go right back up. I think the same is the case with obesity. We need to appropriately weigh the potential risks of treatment against the known risks of obesity. Sure, there are risks of obesity medications. We all acknowledge that, but there are also substantial risks about carrying excessive levels of body weight throughout life. Research needs, I think we need to, I'm wrapping up here, I promise. Research needs, I think we need to pursue combination pharmacotherapy. If any of you have played this game, we call it whack-a-mole in the US, an exceedingly frustrating arcade game where you whack the head of this gopher in this case, and 2 or 3 more pop up. This to me is obesity. It's a chronic disease. Again, our bodies are hardwired. If we think that we can use one medication to target one pathway and that we're going to cure obesity, we're in a dream world. We probably are going to need to knock out many pathways in order to effectively treat obesity, at least in the long term. Trials should be appropriately designed with forethought in terms of predictors of response, again, precision medicine. We should identify the age developmental window of opportunity for when we might start pharmacotherapy, and we need to accelerate pediatric development of adult agents. So back to the title of this debate. What is the current state of childhood obesity management? This is my opinion, okay? I think it's unacceptable. I think we're doing a disservice to the patients that we see, the participants in our studies. We need to do better. We can do better, and we will. I think there's a general feeling of inadequacy by clinical providers, a sense of hopelessness by patients and families because they try really hard and they still don't see good results, most of them. But there are glimmers of hope. And I think what we need to do is challenge our current thinking and pursue fundamentally different strategies. The time for incremental advances in research are over. We need to think out of the box, and we need to go with completely different approaches. We need to innovate. Finally, this is a paper that my colleague Justin Ryder just published in Obesity. I think yesterday it came out, the day before. So this shows basically the risks of treatment and the expected change in BMI, lifestyle modification here, bariatric surgery. We have a big void in the middle here. That could be filled by pharmacotherapy. It could be filled by devices or other innovative treatments. And lastly, I just want to mention our new Center for Pediatric Obesity Medicine at the University of Minnesota. These are my exceptional colleagues and outstanding staff that really do good work and are hopefully going to help us drive this field forward in the years to come. Thank you very much.